Good morning, everyone. Thank you for coming to the first session for the Prognostic and Predictive Use of Cell-Free DNA session. We have a fantastic list of speakers today, and so how the session will begin, I would like to invite all the speakers from the first session to come to the panel and sit on the stage, and then we will call up each speaker one by one, and then we will follow with Q&A for 7 minutes for the first session, and then we will go to the second session. So I'm seeing everyone coming in, so please take a seat at the front, and I would like to invite the speaker for the first speakers, for Dr. Stephanie Graff, Dr. Lajos Pusztai, and Dr. Easton Browning, and Dr. Mitchell Elliott to come on the stage first. So our first speaker is Dr. Stephanie Graff from the Graff Cancer Center at Brown University, and she is going to talk to us about her abstract results from a pilot study exploring ctDNA detection using a tumor-informed assay in the monarchE trial of adjuvant abemaciclib with endocrine therapy in hormone receptor-positive, HER2-negative, node-positive, high-risk early breast cancer. Thank you.
Good morning. I'd like to thank the organizers for inviting me on behalf of author Shireen Loy to present our data, results from a pilot study exploring ctDNA detection using a tumor-informed assay in the monarchE trial of adjuvant abemaciclib with endocrine therapy in hormone receptor-positive, HER2-negative, node-positive, high-risk early-stage breast cancer. The objective of this pilot study is to investigate the technical feasibility of ctDNA detection at baseline and 24 months, as well as the rates and persistence and clearance in a subset of early breast cancer patients from monarchE using the Signatera ctDNA assay. As you all know, monarchE is a randomized trial of 5,637 patients randomized to receive 2 years of adjuvant abemaciclib plus endocrine therapy versus endocrine therapy alone, which demonstrated a significant and sustained improvement in IDFS and DRFS with the addition of abemaciclib. This pilot subset was enriched for IDFS events compared to the total monarchE population, but excluded patients who experienced an IDFS event within the 2-year treatment period. Patients were eligible who had received adjuvant chemotherapy and began endocrine therapy prior to randomization. The existing whole exome sequencing data from primary tumors was used to select patient samples representing a range of tumor mutation burdens for a technical feasibility pilot cohort. Blood samples utilized for this pilot were obtained from the monarchE patients of 178 patients detected at time point 0 and 24 months, and were pre-selected and analyzed for positivity rates and ctDNA dynamics using a Signatera assay developed for each patient. Up to 16 genetic variants were selected for each patient based on whole exome sequencing baseline data. This pilot subset of 178 patients, we observed a 5.6% ctDNA positivity rate at baseline. At 24 months or end of treatment, the ctDNA positivity rate was 23.6%. 39.3% of the pilot patients experienced events. Of the 10 patients, or 5.6%, who were positive at baseline, 7 or 70% remained positive at 24 months, and all or 100% of those patients had disease recurrence. 3 out of 10, or 30%, cleared and remained with no evidence of disease recurrence. 21%, or 28 out of 133, who were persistently ctDNA negative, experienced recurrences. In conclusion, this pilot analysis has confirmed the technical feasibility of Signatera for detection of ctDNA in an adjuvant population of patients accrued globally to the monarchE trial. Pilot sample selections were enriched for patients who had blood detected at baseline and 24 months, IDFS events, and excluded patients who had recurred before the 2-year treatment period. Detection of ctDNA at baseline and soon after completing neoadjuvant therapy was infrequent, with only 5.6% of patients. 3 out of 10 patients cleared ctDNA at 24 months and none developed breast cancer recurrence. 7 out of 10 patients were persistently ctDNA positive and all experienced breast cancer recurrence. ctDNA was detected in 24% of patients at 24 months, which was highly predictive of disease recurrence. Recurrences occurred in 21% of patients who tested persistently ctDNA negative, suggesting an opportunity to improve detection with considerations for more frequent testing, timing of draws relative to administration of active therapy. Future planned analysis of an expanded cohort reflective of the intention to treat population and including additional time points within the 2-year treatment period will further define how ctDNA dynamics may identify patients at high risk of recurrence. Thank you.
Hi, next speaker, I would like to invite Dr. Lajos to talk about his abstract.
So thank you for the opportunity to present on behalf of my co-investigators the updated interim analysis results of the DARE trial. The DARE study is conducted by the Academic Breast Cancer Research Consortium with support from Pfizer and Natera. This shows you the trial schema. ctDNA technology offers the opportunity to identify patients at the molecular relapse stage before they become clinically symptomatic. Our hypothesis is that at that time, an intervention and changing therapy might delay or altogether prevent a recurrence. The DARE trial has 2 components, a screening phase and a randomized phase. To be eligible for the screening phase, patient had to receive adjuvant endocrine therapy and be within 6 months to 7 years of their treatment. They had to have high clinical risk features, including 4 or more positive nodes, or a greater than 5 centimeter tumor, or a 1 to 3 positive node together with high grade or a high genomic risk status, or a multivariate assay predicting greater than 15% risk of recurrence. Patients were monitored with ctDNA every 6 months, and if they turned ctDNA positive, they underwent systemic restaging with CTs of the chest, abdomen, pelvis, and if they were ctDNA positive, imaging negative, they were eligible for randomization to 2 years of fulvestrant plus abemaciclib or continue the endocrine therapy that they were receiving. During the ctDNA screening phase, we wanted to learn the prevalence of ctDNA positivity in an active surveillance setting and the prevalence of imaging positivity when a patient turns ctDNA positive. For the randomized component, we assume a really significant hazard ratio of about 0.5, and to accomplish this, we need to randomize 100 patients. In other words, we hope to reduce the risk of recurrence by 50%. This is an updated result from a pre-planned interim analysis after 200 Signatera tests were constructed to assess the appropriateness of the eligibility criteria to keep the study at a 10 to 15% positivity rate for ctDNA. There are 15 active sites and 544 patients registered for the study. We were able to build 474 tests, and 417 of these yielded ctDNA results. The reason for failure to build a test is primarily due to insufficient tissue. Approximately 12% of the submitted samples didn't yield sufficient tissue to build a ctDNA assay. So out of the 1,120 assays that were performed in the context of serial testing of these 474 patients, 37 were ctDNA positive. This translates into a 3.3% positivity rate at the assay level and an approximately 9% positivity rate at the patient level with an approximately 1-year median follow-up for ctDNA surveillance. Among those who were ctDNA positive, 22 were randomized. 10 patients were not randomized because they were positive on imaging, so that translates into an approximately 27% or 30% imaging positivity rate at the time when you detect ctDNA positivity in the blood in ER-positive patients. The plots show you the dynamics of the ctDNA assay results, and you can see that patients turn ctDNA positive throughout their follow-up period. We have patients who turn ctDNA positive first at a 5-year follow-up time point. We also show you the results of the ctDNamics in the randomized and non-randomized patients, but we have not broken the code, so we don't know who is on the active treatment arm and who is on the control arm. So I want to point out also that approximately 27% of the positive ctDNA results happened during the follow-up period. So initially, ctDNA negative patients turned ctDNA positive during the follow-up. So in conclusion, ctDNA surveillance of stage 2-3 ER-positive HER2-negative disease during the adjuvant endocrine therapy with a median screening period of about 13 months yielded a 3.3% assay positivity and approximately 8.9% detection rate at assay level and patient level. And 27% of positivity occurred during the follow-up phase of the testing. 71% of the patients had a true molecular relapse, which indicates that conducting a trial in this context is possible. So the study continues to be open for high-risk patients and also takes patients who are ctDNA positive in a commercial setting into the randomization component. Thank you.
I would like to invite the next speaker from Royal Marsden Hospital, Dr. Eastern Brand, to discuss her work on the prognostic predictive impact of circulating DNA from the plasma match trial. Every speaker should have known that 4 minutes, so let's try to stick with the 4 minutes allocation. Thank you.
Good morning, everyone. I'd like to thank the organizers of this event for the opportunity to present today. Early changes in ctDNA levels, ctDNA dynamics, may help identify which patients are responding to treatment earlier than imaging. Our study reports baseline and early on treatment ctD analysis from cohort E of Plasma Match. Plasma Match was a multi-cohort trial that assessed the accuracy of ctDNA testing in metastatic breast cancer patients and the ability to match patients to targeted treatment. Cohort E included patients with advanced triple-negative breast cancer treated with a PARP inhibitor, olaparib, and an ATR inhibitor, cerlasertib. Circulating DNA ratio was calculated as the ratio of cycle 2 day 1 ctDNA levels to cycle 1 day 1 levels, pre-specified using the weighted mean variant annual fraction of clonal mutations at cycle 1 day 1. These samples were sequenced using error-corrected targeted sequencing panels for Guardant Health. 75 triple-negative breast cancer patients were enrolled into cohort E, and 51 patients had available samples for analysis. Using the pre-specified methodology, the optimal ctDNA dynamics cut point for predicting outcomes was 0, undetectable ctDNA at cycle 2 day 1. As we can see from the Kaplan-Meier curve on the top here, those in green with suppressed ctDNA at cycle 2 day 1 had a longer median progression-free survival of 12 months versus 4.3 months for those with high CDR. We also identified an association between ctDNA dynamics and objective response rate. Those with suppressed ctDNA had an objective response rate of 85.7% versus 11.4%. Interestingly, those 7 patients with suppressed ctDNA, 6 were wild type for BRCA1/2 mutation and 1 had a BRCA2 germline mutation. Moving on to the bottom half of this slide, we also identified an association between baseline ctDNA and outcomes with an optimal cut point of 6.8. As has been shown in previous studies, we identified an association between baseline ctDNA and median progression-free survival. However, interestingly in this study, we identified there was an association between baseline ctDNA and objective response rate. Those with the low baseline ctDNA based on the optimal cut point had an objective response rate of 40% versus 9.7%. The results from the ctDNA dynamics from cohorts A to D were previously presented at San Antonio in 2020. This slide highlights an important point about the interpretation of ctDNA dynamics. Here we show progression-free survival by median ctDNA dynamics cut point in cohorts A to D on the left and cohort E on the right. Although cohorts A to D were predominantly ER-positive breast cancer patients on mutation-targeted therapies, and cohort E were triple-negative breast cancer on PARP inhibitor therapy and HER inhibitor. Although the median cut point was similar for cohorts A to D at 0.347 and cohort E at 0.356, in cohorts A to D, the median CDR was highly predictive of treatment benefit, which was not the case for cohort E. So in conclusion, clearance of ctDNA to become undetectable at cycle 2 day 1 identified sporadic triple-negative breast cancer patients who benefited from olaparib and ceralasertib. ctDNA dynamic assessment may differ between therapies with different mechanisms of action, and implementing ctDNA dynamics into clinical trials and practice may require distinct analysis for different therapies. Thank you.
Thank you very much. So now I would like to invite the next speaker, Dr. Mitchell Elliott from Princess Margaret Hospital from Toronto, Canada, to discuss his work on longitudinal neoadjuvant and post-operative evaluation of circulating tumor DNA in the TRACER cohort.
Good morning, everyone. I would like to thank the opportunity to present the updated work from the TRACER cohort evaluating a longitudinal tumor-informed assay in early breast cancer. TRACER is a large single-institution cohort enrolling patients with early breast cancer who are set to receive neoadjuvant therapy, the majority of which being chemotherapy. As outlined in Panel A, participants underwent prospective plasma banking at key clinical time points, at baseline, on therapy, perioperatively, and an adjuvant follow-up. The objectives of this analysis were to assess the baseline detection rate of the RADAR assay in early breast cancer, to perform exploratory analysis of ctDNA detection and outcome, to describe therapy-related changes in ctDNA and outcome association, and to assess lead time to clinical recurrence. Baseline whole exome sequencing was performed on diagnostic biopsy tissue with 20% or greater cellularity. Using this whole exome sequencing, up to 48 tumor-specific variants were selected for RADAR panel generation, as outlined in Panel B, using the tumor workflow. All plasma time points available for assessment were included in this analysis. It's stuck. Yeah. Oh, and we're too far. There we go. In this analysis of TRACER, 119 participants were included, for which 114 had baseline samples for analysis. 17 clinical recurrences have occurred to date, and one patient with adjuvant ctDNA detected has yet to have a clinical recurrence but remains on clinical follow-up. Drawing your attention to Panel A, the baseline sensitivity of the RADAR assay amongst all receptor subtypes was 77%. This varied based on the clinical receptor subtype, highest in triple-negative breast cancer at 90%, followed by HER2-positive breast cancer at 76%, and then hormone receptor-positive breast cancer at 70%. Baseline clinical variables such as tumor size and nodal status were not associated with baseline ctDNA detection. However, baseline clinical grade as assessed on the diagnostic biopsy was statistically significant and associated with ctDNA detection. We evaluated relapse-free survival stratified by mid-neoadjuvant treatment ctDNA detection. As indicated in Panels E and F, persistent ctDNA detection midway through neoadjuvant treatment was associated with an increased risk of disease relapse in this cohort for both hormone receptor-positive and triple-negative breast cancer. Turning your attention to Panel G, the median lead time in this analysis was 152 days from ctDNA detection in the postoperative and adjuvant period to disease recurrence, with a range of 13 to 862 days. In conclusion, the RADAR assay has high sensitivity with ctDNA detected prior to neoadjuvant therapy in most participants. Baseline ctDNA detection rate varies with receptor subtype, but is highest in those with triple-negative breast cancer. ctDNA detection at baseline was associated with clinical grade, but no other clinical variables. And persistent ctDNA detection midway through neoadjuvant therapy is prognostic of clinical recurrence in this cohort of hormone receptor-positive and triple-negative breast cancer. And RADAR can identify ctDNA with a potentially clinically meaningful lead time in the postoperative and adjuvant setting. Thank you.
Thank you very much. Now I would like to invite our discussant, Dr. Ben Park from Vanderbilt University, to discuss all the four abstracts. Thank you very much.
Thanks, and good morning, everyone. I'm impressed by the number of people here for a 7 a.m. talk. I'm hoping this is the right version. I just got a phone call and a voicemail and an email that they didn't have my slides. So I want to talk a little bit about prognostic versus predictive, the title of this discussion. I think most in the audience recognize that prognostic is really something that is we use for saying, hey, at 5 or 10 years, what is the likelihood of recurrence or some sort of event, overall survival, et cetera. And on the other hand, predictive really means what is the likelihood of an intervention like a drug that will actually work based upon the biomarker. There are some biomarkers that can be both. I'm putting up Oncotype, which many of you are familiar with, which is actually both and can give you both prognosis, what is the likelihood of recurrence at 9 years, as well as predictive, what is the likelihood of benefit from chemotherapy. But I also want to talk a little bit about clinical validity versus utility and where we are in the ctDNA space for breast cancer. I think there are many examples where we have a clinically validated biomarker, and that can actually be an FDA-approved test. But clinical utility really refers to this idea that can we do something with that information and that biomarker that will lead to a change in outcomes, whatever those measurements will be. I think an example is on the upper right-hand corner there, circulating tumor cells done by Dr. Dan Hayes and his group, looking to see whether in the SWOG trial, changing therapies earlier based upon higher levels of CTC would afford a better outcome. And in fact, that was not the case. And so that's an example where we have clinical validation, but not utility. On the other hand, for ctDNA, most of what we've done in the field right now is that we have the qualitative aspects. And an example is if you take a ctDNA measurement from a patient and there are PIK3CA mutations, that patient can now get targeted therapies. So getting to the posters that were really very nicely done, and I'm impressed we're on time. I think in the first one that you heard about the monarchE trial, this is where we now have evidence that in fact you can pick up potentially minimal residual disease by ctDNA. I think one of the things that we know is that ctDNA is prognostic, and I think that was reconfirmed in this particular study and analysis. The harder question, or the harder part, is that we still don't have a good negative predictive value, and I think that was put in the slides. And we still need to show some sort of clinical utility, meaning that even though we know that there are patients who are positive after their 2 years of therapy, can we actually do something to afford a better outcome or change in those patients? And those are the types of trials that are being planned right now, and some are ongoing. Similarly, this was a study that you just heard about. Both of the prior and the study used the Signatera assay, and as was actually nicely demonstrated by Dr. Pusztai, very similar types of data where, in fact, the negative predictive value may not be that high. In this particular case, it looks like the patients that we're picking up also have more advanced stages, and so that's leading to, again, the greater than 4 lymph nodes going forward, so higher anatomical staging in order to pick up more of these patients by ctDNA. Again, I think that one thing that we always have to think about is what was put out there is the inability to get tissue or adequate tissue sometimes, and even though the only a smaller proportion of the assays, I think it was up there, is 12%, had WS failure. The reasons for those WS failures, 60% of the time, was because of the insufficient tissue for testing. And then also from the Prince Margaret group that you just heard about, Dr. Elliott, one of the things I wanted to put up there, by the way, forgive you for this mishmash, I thought we could do animations, but we can't. In the upper left-hand corner, I think most of us now in the ctDNA business recognize that the more shots you take on goal is the term I like to use, meaning the more markers you're gonna assay, the better odds likelihood of picking up ctDNA as a measurement of MRD. And so if one has only a few markers and one's using a limited source of blood, one may not pick up that mutation in that actual sample, whereas opposed to looking for a lot of different mutations with a given volume of blood allows for a higher sensitivity and maybe specificity. So with that in mind, this particular group used the radar assay, which you just heard about, which is 48 markers rather than the Signatera, which was 16. And that may improve the sensitivity and overall ability to actually detect disease a little bit earlier, or maybe a lot earlier than one would actually think about with using an assay that only measures a few markers. I think that's kind of demonstrated also that there is prognostic significance, or maybe predictive in that case, looking at the mid-cycle ctDNA analysis and what that means in terms of overall disease-free recurrence. And I think one could imagine that you could use this in the future for clinical utility if you could prove, for example, that if you clear your ctDNA, maybe those are patients that wouldn't need surgery in the future because they achieve pathologic complete response. I'm putting in the lower right-hand corner there our own study that was done or started a number of years ago when I was at Johns Hopkins looking at the clinical utility of that particular primary objective. So in conclusions, hopefully, I think, again, most people in this audience don't have to be sold on this, that prognosis is different from predictive for ctDNA and all biomarkers, but studies support that ctDNA for breast cancer could really be derived for both uses. Clinical validation, I think, really has been demonstrated for ctDNA, not only in breast cancers, but many others. And so I think with that knowledge, we now have a foundation and a base to really start doing interventional studies that are using ctDNA as an integral biomarker. And so clinical utility really is, again, whether or not we can do those studies and prove that interventions based upon ctDNA qualitatively or quantitatively are going to lead to better outcomes. There are examples, as I already mentioned, about PIK3CA mutations, but I think many in this audience are also now familiar with ESR1 mutations in olestrin. And then finally, we really do need further studies, the types of studies that we're all used to, looking at randomized control groups, seeing whether or not intervention on a marker for ctDNA, whether qualitative or quantitative, is going to lead to better outcomes. And with that, I thank you.
Thank you very much, Dr. Park, for the fantastic discussions. So now the floor is open for question and answer. So I would like to invite anyone to come to the speaker phone to ask the questions. A microphone for them. Please introduce yourself.
Hello, Andrew Tutt, London. Thank you very much. Really excellent session. Could I ask Dr. Elliott, in the tracer cohorts, in patients...
A little bit.
Can you hear me okay?
Yeah.
In the tracer cohort, where patients had a sample, I believe, right at the end, just before surgery, what was the relationship between the radar assay's ability to detect ctDNA and RCB status, or what proved to be the case within the tissue? Do you have any data on that?
Better now? Okay, good. That's a great question. So we do have that data, is specifically for the perioperative time points. Only about 5 patients in total had ctDNA detected before or after surgery. All of them had RCB2 or 3 disease. And interestingly, but 1 patient actually had a subsequent clinical recurrence.
Thank you.
Yes, I'm curious about the timing between sampling the tumor and assaying the blood with respect to the variability you might experience with, say, biopsies that are 6 months or a year old versus those that are available immediately. Is there much of an effect of lag time or subsequent therapy post the biopsy being taken that would affect the results of the assay?
Can you repeat the question? It's hard to hear up here, Chris.
Oh, I'm sorry. So the question is the timing between sampling the tumor and assaying the blood. It's not often that we can get biopsies immediately prior to starting a trial. So is there much of a drift that you find between the tumor and the blood, say if you have a biopsy that's a year old?
Yeah, that's a great question. In this specific analysis, it was all retrospective using banked or clinical specimens. We do have some analyses that are pending from patients with metastatic recurrence, and we'll be looking into that as well.
I have some flooding questions for Dr. Graff from online, so I would like to ensure that the online people are able to ask the question first. So there's 2 questions related to your presentation. In monarchE, is there a later time point of ctDNA allocation at 5 years? And also, in your pilot subset was enriched for risk of IDFS events. How and using which criteria? Thank you.
Thank you for the questions. So yes, there are numerous other time points for data collection in the translational cohort of monarchE. The time points included 3 months, 6 months, 2 years, 5 years, or 3 months, 6 months, 24 months, 3 years, 5 years, and at disease recurrence. And those additional time points we hope to analyze in follow-up, so look for more soon. And IDFS is defined using standard criteria in the original manuscript. We enriched this population for IDFS events, again, because it's a pilot feasibility cohort, so we wanted to make sure we were able to capture recurrent events using the Signatera assay.
Thank you. The microphone for that, please.
Yeah, Basic from McGill. For Mitchell, I guess the Garden assay, and also for the, well, we'll start there. You looked at the other time points in neoadjuvant. You look at the earlier ones as well, and the pre-op. Which was the strongest RFS predictor? You showed us only the mid-cycle one, but you also have data, I guess, from the earlier time point, and as well as the later one. And did this vary in terms of the three subtypes that you're looking at?
Yeah, it's an excellent question. So as per our previous poster last year, we looked at pre-cycle 2 time point specifically. In the updated cohort analysis within more events, it was actually not statistically significant, but the mid-cycle detection rate was the most prognostic, including multivariable analysis correction.
And that's compared also with the preoperative one?
Preoperative time point, because the actual amount of, like, the number of time points that were positive, it was, there were 3 patients that had preoperative positivity, of which 3 of 3 recurred, but again, the number of events was actually quite low.
And hold on, there's also another question for Dr. Pusztai from online. So their trial, how frequently are you running the assay to check for ctDNA positivity? And what is the latency, in your opinion, from ctDNA detection to evidence of metastases?
So the study actually is blinded for that outcome yet. So obviously that's what we want to find out in the randomized component of the trial. But I can't tell you the recurrent status of the randomized patients. But there are no recurrences among those who are ctDNA negative.
Thank you very much. Speak.
Wolfgang Jan, University of Ulm, Germany. Another question, Dr. Pusztai, or 2 short questions. Wonderful presentation, Lajos, and wonderful study. I have 2 questions. First question, could you maybe comment briefly on the role of ESR1 mutation in the randomization part of your study? And second question, the rate of distant metastasis you detected at a ctDNA positive result is much lower than in the Nick Turner CTRAC study, which was 70%, if I remember. Could you comment, is that because of tumor biology, or why do you only observe 30% compared to the 70% in the CTRAC study?
So the tracker trial was for triple negative disease, and I'm not quite sure about the way patients were staged at the beginning or throughout the study. So this is ER positive disease, and I think what we observe is actually the reality, and it's very encouraging. So there is indeed a lead time bias between actually being ctDNA positive and developing clinical disease. So remember, this is probably the first study that ever did ctDNA monitoring testing at the same time when you turn ctDNA positive, also get imaging. So that one, this ours, and the Nick Turner study did this. And so only about 25% of the patients who are imaging positive at the time when they are ctDNA positive. And with regards to the ESR1, so the Signatera assay does not actually report out, as of yet, the actionable mutations. But so I can't comment on that, but they are developing an assay that would actually combine the actionable mutations with the monitoring capability.
Yeah. Thank you very much for all the question and answer. Due to the interest of time, we need to move on to the second session. I'm sure the speakers would be very happy to discuss many of the questions offline. And I would like to invite the second group of speakers on the stage. Dr. Emily Podany, Dr. Wolfgang Yanni, Dr. Heather Parsons, Dr. Mariana Sharifi, and Dr. David Cescon, please. So Dr. Emily Podany from Washington University in St. Louis will present her work on the differences in the ctDNA genomic profile and outcomes of black and white patients with metastatic breast cancer, results from a large multicenter consortium. Thank you very much.
Thank you. Thank you everybody for being here so early, and thank you for inviting me to speak. So I'm presenting on behalf of the consortium. Everybody's listed here. So we have quite a large consortium with a lot of clinical data as well as genomic data. With so much data, including clinical correlates, we asked this question: could there be racial differences in ctDNA genetic profiles in metastatic breast cancer patients? This could impact treatment response, it could impact outcomes, so we did a retrospective cohort study. There were 1,327 patients in this retrospective cohort. You can see, and it's on my poster in the back, I won't belabor it, but we had quite a diverse cohort in comparison to some cohorts. We had 10% black patients, 80% white patients. This race was patient reported, so we don't have ancestry data, unfortunately. The other 10% were other races or were not reported by the patients. We did univariate and multivariate analyses to evaluate single gene mutations and genetic pathways in both the entire cohort and then specifically in the hormone receptor positive HER2 negative population, which was our highest population. We also looked at the prognostic impact through multivariate analysis, and we looked at overall survival. So our results I'm going to talk about twofold. So the first is that we found that black patients have significantly higher rates of GATA3 single nucleotide variants and CCND2 copy number variants. So all of the data is here and also in the back, but it's interesting that the HER2 negative hormone receptor positive group actually had slightly different results in black patients, but all of what you see on the left-hand side, this was all significant. The other thing we found, unfortunately, as everyone in the room knows, there's quite a striking inequity between black and white patients in treatment outcomes. And so, unfortunately, our research did support that. So what you see on the right-hand side is the overall survival curves. And so overall survival from the time of ctDNA testing in these metastatic breast cancer patients was significantly lower in black patients, even after adjusting for all the other variables we looked at. We also looked at the mean allelic frequency. So overall, there was no difference in mean allelic frequency between black and white patients. However, patients with a higher mean allelic frequency did have a worse prognosis. And overall, which is the orange curve you see at the bottom, black patients with the higher mean allelic frequency did have the worst prognosis. So to our knowledge, this is the largest clinical genomic data set examining ctDNA differences across black and white patients. GATA3 and CCND2 are not currently targetable. Oh, that's exciting. Well, it's okay. I know the slide. So they're not currently targetable by current treatments. There is some discussion on whether CCND2 could be targetable, and I know that a university in Taipei is working on seeing if that's possible, and GATA3 is also being looked at. But overall, if these are not targetable treatments, and if we don't start pursuing potential treatments for them, we could see the inequities getting worse. The other thing we looked at is that the overall survival curves had an early separation. So there's likely both genetic but also socioeconomic and social determinant of health issues here. We're working with Guardant Health to try and find a sort of a real world analysis, and we're looking at a larger cohort of patients. So I'm really looking forward to working with them on that. And thank you so much for your time and attention. I appreciate it.
Thank you so much. We have several technical problems when we first begin, mic and slides and timers. So, well, thank you for all the speakers keeping in time. Do we have the slide back up? So now, before I invite the other speaker, Dr. Wolfgang Jani from the University of Ulm, Germany, to discuss her work on analysis of ctDNA for the detection of minimal residual disease using a tissue-free multi-omic assay in patients with early-stage breast cancer. Sorry, is that he? Sorry.
Just on time. Good morning. Thank you very much. On behalf of my co-authors, I would like to thank the organizers for the ability to present the data of ctDNA testing within the SABCS trial this morning. The SABCS trial was basically a chemotherapy study we performed in Germany And we did blood sampling before chemotherapy, after chemotherapy, and at 2 years and 5 years after the completion of chemotherapy. Here, we present the data of ctDNA testing at the 2-year time point, so the typical time point for breast cancer surveillance in 311 patients. We used the Guardant-Real test, which is a tumor-agnostic test looking at breast cancer-specific alterations in combination with methylation patterns. And the objective, obviously, was to evaluate the sensitivity and specificity for recurrence, prediction to determine the prognostic significance of the ctDNA testing in the post-adjuvant surveillance period of our patients. These are the key findings of our analysis. ctDNA was detected prior to distant recurrence in 13 out of 38 patients, 34% in 9 of 15, equal to 60% of the patients if the blood sampling was within 1 year of the distant recurrence. The specificity was 97.7% with 6 patients without proof of distant recurrence within the period of follow-up time of about 5 years. ctDNA was detected up to 28.6 months prior to the clinical diagnosis of distant metastases, and the detection of ctDNA was associated with a nearly 14-fold increased risk for distant recurrence and about 17-fold increased risk for subsequent death. In conclusion, the detection of ctDNA after adjuvant chemotherapy was highly prognostic and demonstrated high specificity in early breast cancer, in this early breast cancer cohort. ctDNA testing, of course, warrants further investigation as a tool to identify patients with early breast cancer which are at high risk for recurrence and might benefit from early treatment intervention, like has been mentioned from the discussant early on. Following these data and other similar data, we are very happy to roll out the SURVIVE study program in Germany, which will also be presented in a trial progress poster by Franziska Merkel later today. The SURVIVE study itself will randomize 3,500 patients between standard of care follow-up versus liquid biopsy-based surveillance based on CTC screening and also ctDNA screening, and there will be 2 interventional trials associated with the SURVIVE trial. Thank you very much for your attention.
Thank you very much. So I would like to invite the next speaker, Dr. Heather Parsons from Dana-Farber Cancer Institute, Boston, to discuss her work on liquid biopsy determination of HER2 status in breast cancer from the novel epigenomic platform.
Thank you for the invitation, and on behalf of my co-authors, I'd like to share with you the liquid biopsy determination of HER2 status in breast cancer results from a novel epigenomic platform. My disclosures. HER2 status assessment currently relies on complex tissue-dependent algorithm that is optimized for binary extremes of HER2 positive versus HER2 negative. Additionally, challenges in obtaining biopsies, inter- and intratumoral heterogeneity, and a lack of IHC scoring reproducibility in HER2 1+ and 2+ disease necessitates novel biomarker approaches. We developed a HER2 classifier via feature selection from epigenomically profiling breast cancer cell lines and cross-validated the final classifier using standard leave one out schema. On the right, you can see we profiled 130 patients with metastatic breast cancer who had blood drawn within 6 weeks of a new tumor biopsy with HER2 and ER IHC assessment, and assess the assay from 1 milliliter of plasma. On the left, you can see a heat map representing hundreds of differential loci from enhancers, promoters, and DNA methylation found to be differential between HER2 positive and HER2 negative breast cancer. Though we detected many differential sites within the HER2 amplicon, most were actually outside of this region, highlighting the detection of transcriptional activity downstream of HER2. On the right, you can see the cross-validated HER2 classifier with ROC curves, and on the left, we show with all patients included, we achieved an AUC of 0.88, and on the right, when including patients with detectable ctDNA, with a cutoff of 3% via I-core CNA, achieved an AUC of 0.97. Due to the efficacy of anti-HER2 ADCs in HER2-low population, we know about the significant need to identify patients in this setting. And so we applied the multi-analyte HER2 3+ versus 0 classifier and show here on the left that it can provide early insight into the potential for HER2-low classification. We are continuing with further work to build on these results to develop a robust HER2-low classifier. But ultimately, the predictive value of the biomarker will really be the gold standard to demonstrate clinical utility, given the challenges with HER2-low status currently. So in conclusion, this is a promising proof of concept from a novel liquid biopsy platform profiling tumor genome-wide transcriptional regulation from 1 milliliter of plasma. Has potential to assess and monitor HER2 status in patients with metastatic breast cancer with an AUC of 0.97 with plasma with detectable ctDNA. Given the evolution of disease over time in the metastatic setting, non-invasive revelation of metastatic breast cancer biology could be potentially high impact far beyond the HER2 status assessment. HER2 low and ER classification work is ongoing with promising ER results with an AUC of 0.9 from plasma with detectable ctDNA. Please see our poster for more information. The study is certainly limited by its retrospective nature, and our future work will include evaluation in additional cohorts as well as prospective application of the biomarker. Thank you.
Thank you. I would like to invite the last presenter of the abstract, from Dr. Mariana Sharify from University of Wisconsin, to talk about her work on fragmentomic analysis of a circulating tumor DNA targeted cancer gene panel that can discriminate ER status in metastatic breast cancer liquid biopsies.
Thank you so much. I'm excited to have the opportunity to share with you our work showing that fragmentomic analysis of a targeted ctDNA sequencing panel can discriminate ER status in metastatic breast cancer liquid biopsies. And I have no disclosures. So DNA fragmentation patterns in ctDNA whole genome sequencing reflect differences in nucleosome positioning and chromatin structure of their cell of origin. Multiple groups have therefore shown that these fragmentation patterns can be used to infer tumor phenotypes, including ER status in breast cancer. However, whole genome sequencing is not cost-effective for detection of clinically actionable mutations from ctDNA, which is typically performed using exon-focused targeted sequencing panels. We hypothesized that differences in exon 1 nucleosome positioning between repressed and expressed genes could lead to differences in exon 1 fragmentation patterns that would be detectable with a targeted sequencing panel. This would then allow us to infer both fragmentomic phenotypes and also perform mutation detection from the same ctDNA assay. Indeed, as you can see on the right here, when we compared ctDNA fragmentation patterns in whole genome sequencing, shown on the y-axis, with tissue biopsy gene expression, distinct fragmentation patterns corresponding to gene expression levels are seen not only in the promoter region, but also extending into the first exon, as you can see here with highly expressed genes in red and repressed genes in blue. To test whether these differences in exon 1 fragmentation patterns can be used to infer tumor type and subtype from a targeted ctDNA sequencing panel, we assembled a multi-institutional cohort of 320 ctDNA samples from patients with metastatic cancers, including 90 HER2-negative breast cancers, as well as 14 healthy donor controls. ctDNA was sequenced with an in-house targeted 800 gene panel, and then exon 1 fragmentation patterns from a training subset of the cohort were used to train a machine learning classifier to predict tumor type as well as ER status within the breast cancer samples. This training utilized 10-fold cross-validation, and model accuracy was then tested in the independent validation subset. As you can see in the middle here, with our AUC curves, this approach was able to predict both tumor type as well as breast cancer ER status highlighted here with high accuracy. On the right, you can see that we also saw at the individual gene level, there were significant differences in ESR1 fragmentation patterns corresponding with expected differences in ER gene expression between ER positive and ER negative breast cancers. And we also found this with additional genes as seen on our poster. In summary, we found that fragmentation patterns from cfDNA targeted sequencing accurately identify ER status in metastatic breast cancer liquid biopsies. We also found that exon 1 fragmentation patterns at the gene level showed expected differences that match the expected gene expression differences between the cells between ER positive and ER negative breast cancer. This approach then may have utility in discriminating fragmentomic tumor phenotypes in addition to mutation detection using targeted ctDNA panels, and could potentially be used for the development of biomarkers for treatment selection beyond mutation type using this approach. I'd like to thank my collaborators as well as the patients who participated in the study, and thanks for your time.
Thank you very much for another speaker speaking without a slide. Thank you so much. Now I would like to invite our discussant, Dr. David Cescon, to discuss all the abstracts together.
Good morning and thank you. Thanks to the organizers for the opportunity to discuss the second set of presentations. And thanks and congratulations to the speakers for their great work and for sharing additional details with me prior to today's session. I'm hoping that all retain my slides for the whole presentation, although certainly our presenters deserve extra congratulations for proceeding despite that. In the second set of presentations, we've seen attempts to integrate ctDNA analyses to uncover additional tumor biology beyond the type of mutation counting that the initial studies presented in the first half of the session focused on. These are my disclosures. When we think about applications of ctDNA in breast cancer, we can think of some broad potential use cases. Detecting of disease, either initially or upon recurrence, as some of the earlier presentations highlighted. Measurement of treatment response, or lack thereof, that might influence our ability to deliver more effective or individualized treatments. And the identification or insight generation into disease biology that could provide new leads or opportunities for drug development or treatment administration. In all cases, our goals of developing these assays are to demonstrate clinical utility, to enable informed interventions for better patient outcomes, either by improving outcomes or reducing harms of ineffective therapy. Circulating tumor DNA that is released into the circulation contains a myriad of information about that tumor. Gene alterations we're very familiar with, either using targeted panels in patients with advanced disease or now tracking fingerprints of tumors across either early or late disease settings. In addition to the mutational information, the circulating tumor DNA that is released into the circulation includes information about the epigenetic status of that tumor. We recognize in the use of our biomarkers in breast cancer that mutation alterations provide only a limited window into biology. Gene expression status, as we commonly use in early breast cancer, such as in multi-gene panels for chemotherapy decision-making, reflect gene expression changes that are influenced by the epigenetic status of that tumor. Two of the presentations we heard in this session focus on trying to identify those epigenetic changes in the circulating tumor DNA released into the circulation and infer those biological features of the tumors from which they arise. I've grouped these two presentations together as they're thematically similar. Dr. Sharifi's presentation examining fragmentomic analyses to characterize ER status, and Dr. Parsons' presentation focused principally on HER2 status using a different approach to epigenetic analysis. Sure, you'll take the opportunity to look at the posters and understand specifics of these applications, but I wanted to highlight a couple of the important differences in the approaches and how these relate to the future development of assays that could use these approaches. Dr. Sharifi's presentation importantly attempted to use standard panel-based circulating tumor DNA fragmentomic analysis to derive this additional biologic information. So here this is a standard assay with an additional layer of bioinformatic analysis to extract the maximal biological information possible. And here focus on a relatively simple use case, identifying whether tumors are ER positive or ER negative. In Dr. Parsons' presentation, a novel assay requiring an upstream processing of the DNA, immunoprecipitation, is used. Again, here in an initially relatively simple use case, identifying HER2 status, but potentially amenable to other biology. So when we think of trying to translate this biology or characterization of biology through epigenetics into biomarkers, there are a number of considerations that follow these initial successful proof of concept study. What are the analytical requirements of these kind of assays? What kind of sample is required? How much sample is required? What disease settings is this relevant to? How much circulating tumor DNA needs to be in that sample? What are the laboratory assay conditions, and are they locked down? In addition, what's the gold standard of these analyses, gold standard of these assays, either when training the assay or when assessing it? We saw in Dr. Parsons' presentation there was contemporaneous biopsy for HER2 status, but we know that circulating tumor DNA arises from the full tumor burden in an individual patient. And is that biopsy the gold standard truth, or is discordance between those a reflection of tumor heterogeneity that we know exists? Also, we must think about what the test characteristics are, not just for groups of patients, but for an individual patient. Finally, is the test fit for purpose, or could it be fit for purpose? And what is the path to demonstration of that clinical utility? And I think we would agree for these type of assays that largely the clinical utility will lie in, can it predict response to a therapy that it's attempting to measure a surrogate biomarker for? Moving to the second presentation, which uses an epigenetic approach here for MRD detection. So the Guardant assay uses differential methylation to try to identify a tumor signal in the minimal residual disease setting. We heard other approaches to this using mutation detection, but this provides the possibility of using a tumor-agnostic assay where the complicated logistics of acquiring a tumor sample and developing that individualized assay are not required. These are the data that Dr. Yanni presented from the SUCCESS-A trial, where we can see a very large difference in the outcomes of patients who do or do not have circulating tumor DNA detected at a single time point. As we see with other assays, a single time point has low sensitivity for detecting all recurrences, and many patients recur with a negative assay. On the other hand, here with this assay, we see that some patients with a positive assay do not recur. So while the specificity of this assay was high at 97%, roughly 1/3 of patients who tested positive did not recur. And considering this positive predictive value is essential when we think about how we might act upon this information. In addition, as we heard before, these retrospective studies do not include contemporaneous imaging, and so the knowledge of whether this is truly MRD or whether it's rather clinically undetected metastatic disease is uncertain until those prospective studies are performed. Moving to the last presentation, evaluating the important question of population diversity in ctDNA profiles, we heard very nicely from Dr. Podany that they were able to observe differences in Black and non-Black patients with breast cancer from a heterogeneous cohort. This follows on other work based on tumor analyses, including this example published earlier this year, which evaluated differences informed by genetic ancestry between breast cancers and other cancers arising in Black and non-Black patients. This is obviously very important to understand disparities that we see in outcome, and these differences in ctDNA must be considered in the context of the other clinical factors that we know differ between these populations. Importantly, we must ensure that the tests that we use to make these comparisons capture not only differences in disease, but also host biology that exists in diverse populations. And of course, we can only see the differences that the tests can capture. So if the tests haven't included some of those differences in the beginning, these kind of analyses will not reveal them. So to summarize, we've seen that rapid technical advances are opening up the opportunities to interrogate breast cancer biology through ctDNA, creating enormous opportunity, but also bringing enormous complexity in both the assays, patients, and treatments that must be considered as we evaluate these tests to ultimately create biomarker assays and tests with clinical utility. So I think we're early in the days, but there's great potential ahead and much work to do, just as there is in San Antonio today. Thanks for your attention, and congratulations again to the speakers.
Is there any questions for the speakers? Okay, thank you very much for everyone coming to the session. Thank you. That concludes the poster spotlight session today. Thank you very much.